Hello and welcome to your final lecture of the semester. We are going to talk about inflammatory and structural disorders of the heart. When we are talking about infectious and inflammatory cardiac disorders, the diseases have multiple etiologies. So it makes it very difficult to diagnose. The clinical manifestations can look a lot like an MI. They can be very vague. They can look like flu-like symptoms. We are going to focus on endocarditis and pericarditis. Infective endocarditis, here's a definition. It is an infection of the endocardial surface of the heart. It includes the valves. It can be caused by bacteria, a virus, a fungus. The most common organism is Staph aureus or Strep viridans.
Try and find a way to fill the back of my truck with something so it doesn't drift as bad.
Look and see if there's bags of salt down the basement.
I was going to put logs in. Yeah, that'll work. No, because that'll use them. I was thinking about putting the box in the back with just a shit ton of crap. I'll put some salt at the bottom of the box and I'll put logs on it. Will Dad be using the salt?
Well, David, let's just wait to see what he says.
Well, Dad said that was the original plan. Was Dad wanted to put something in my box and then put the box on top of the wheels.
Classifications, etiology, and pathophysiology. There are two classifications that we talk about when we talk about infective endocarditis. We talk about subacute and acute. Subacute infection affects those that have a pre-existing condition, so their valves are already damaged from some sort of a previous insult, and the clinical course extends over a long period of time. When we talk about acute endocarditis, we're talking about those who previously had a healthy heart valve, and then this infection presents itself as a rapidly and very progressive illness. So acute and subacute infections are technically the major classifications, the official classifications, if you will. But most physicians classify endocarditis by its cause. And you will see, in most cases, IV drug abuse, infective endocarditis, or fungal endocarditis, site involvement like prosthetic valve endocarditis. So that's how we often see it classified in the hospital. So let's talk about the etiology, the pathophysiology. We said endocarditis is an infection of the endocardium, or the inner layer of the heart. So what we're really saying that it is a microbial infection of the endothelial lining of the heart, which includes the valves. So the most common reason for developing endocarditis is some sort of an underlying structural problem. So let's take, for example, the person who had valvular disease because they had rheumatic heart disease as a child. because the valve in the heart, usually the mitral valve, is damaged because there is endothelial damage there, the basement membrane of the valve is exposed to turbulent blood flow. And the damaged valve or the damaged endothelium attracts platelets, and the platelets adhere to the surface and they start to develop a non-bacterial thrombi. So platelets and fibrin clot, and they form little tiny blood clots on the valve leaflets, the little flappers that work the valves in the heart. So as a normal course for someone who has damaged valves, we have a lot of turbulent blood flow going through these valves. The platelets run through, and platelets and fibrin are attracted to this damaged endothelium, and they make blood clots, just like we talked about when we talked about sepsis, and the endothelium became damaged and the platelets adhered there. We're talking about the same thing. So we have this non-bacterial thrombi that form on the leaflets of the valve, usually, in most cases, in many cases, the mitral valve. And then there's some kind of an infection that is introduced. Bacteria enter into the bloodstream through some sort of a portal of entry. What would that be? A wound, a biopsy site, patient recently had a pacemaker placed, IVs that we put in the person, catheters that we use, a colonoscopy, dental procedure where they're having, root canal, IV drug abuse. And then the organism has entered into the bloodstream, and the organism travels through the blood, and it makes its way to the heart, and it settles on the valves and the endothelium. Remember that these valves they're already damaged, they already have blood clots on them. Now this bacteria or fungi, whatever it would be, or virus, enters into the blood through some portal of entry, and it travels its way to this already formed blood clot on damaged endothelium, and it starts to build up bacteria, if you will. Let's take a look at the next slide. It starts to build up bacteria. So here's a picture of a valve, and the endothelium was damaged. The platelets adhered to it. The bacteria got in there, and they started traveling around, and they landed on that blood clot, and then the bacteria start to enlarge over time. And now you see the arrow in the middle of the picture there. Now you can see these bacteria are forming, bacteria and clot combination are forming what we call vegetations. And in these vegetations, the bacteria and the thrombus are holding on to the leaflets of the valve, and it's making it difficult or interfering with the valve's ability to function. And we're going to talk in a few minutes about valves and how they work, but if you recall, if you think about your anatomy and physiology, 2 or 3 leaflets, which are kind of like swinging doors in each valve, and those doors have to swing freely to open and close and make a tight bond. So you can imagine this blood clot bacteria clump or vegetation is holding on, and it's interfering with the the valve's ability to do its job. In addition to that, look at that vegetation in this picture. One of the biggest problems that we have is that these infected thrombi, these vegetations, can break off and cause an emboli. In fact, according to your textbook, 25 to 50% of the people who have infective endocarditis will throw a clot. If the valve that's affected is on the left side of the heart, and we break off a piece of this vegetation, that blood clot or that emboli will go to the brain, it will go to the kidney, it could go to the spleen, it could go to an extremity. If the valve that's affected is on the right side of the heart and we throw a clot, we would throw that emboli to the lungs and it would result in a pulmonary embolism. So let's do a quick review. So we have a previously damaged valve from, we're going to say, rheumatic heart disease when we were a child. And so the basement membrane of the endothelial is changed and it's exposed to turbulent blood flow. And so blood clots, platelets, and fibrin are going to stick to that damaged endothelium and they're going to make little blood clots. Then there was some sort of a problem. There was IV drug abuse. There was an IV that we put in. We had a pacemaker. They had a root canal. There was some portal of entry for some organism to come in. And that organism traveled around in the blood and made its way to the damaged endothelium and to the platelet. And so the platelet and those bacteria begin to enlarge. And when they enlarge, they form that vegetation that we saw on the previous slide. And those vegetations are heavy and they hang on the valve. And when the valve can't do its job, the person is at risk for developing heart failure in a most extreme case. And the other problem, other than the valve not being able to do its job, is that those vegetations are not stable and they can break off. And according to your textbook, 25 to 50% of the patients who have infective endocarditis do experience an embolism. If the valve that's affected is on the left side of the heart, that embolism goes out to the body, to the brain, to the spleen, to the extremity, to the kidney. If the valve that is affected is on the right side of the heart and we throw an embolism, a piece of that vegetation breaks off, it makes its way to the lungs. I'm just taking a look at my notes here to make sure that I said everything that I want to tell you. And I want to make sure that I said the most common organisms that cause this infective endocarditis are Staph aureus and Strep viridans. The Strep viridans is a normal bacteria that's in our mouth, our throat, and in our GI tract. And of course, Staph aureus is the most common organism on our skin. And Staph aureus is the one that is most responsible for causing problems with the valves on the right side of the heart, mostly because it is an organism that comes from the skin. And we had some sort of an insult where, maybe we were putting in an IV or a PICC line or something like that, and that Staph aureus did enter into the bloodstream through that portal of entry, and of course it would make its way and settle into the right side of the heart. Now I'm going to advance the slide and we're going to talk about some clinical manifestations and some diagnostic studies. Okay, so the clinical manifestations of infective endocarditis are often very nonspecific. It can involve multiple organs, but the diagnostic, the hallmark signs and symptoms the thing that should set off bells and whistles, the things that you should remember to be able to reproduce on a test, is that the major sign would be a new or a changed murmur. I'm going to say that again. The hallmark sign would be a new or a changed murmur, followed by signs and symptoms of heart failure, early heart failure. %90 of the patients will have a low-grade fever. They may have chills, fever, chills, malaise, maybe even night sweats, even though we tend to associate night sweats with tuberculosis. Fatigue, so that sounds like, those symptoms that I sound just like what we talked about when we talked about tuberculosis. And that's why those signs and symptoms, along with a new or a changed murmur, indicate that we're dealing with something different than many of the other illnesses that we have out there. Okay, so let's see what else. We could be talking about what they call splinter hemorrhages. They call them Janaway lesions. I don't know if you need to know that word, Janaway lesions. But there's little splinter hemorrhages that happen particularly in the nail beds. If it is a subacute form of endocarditis, we may see clubbing of the fingernails because they had a decrease in cardiac output and a decrease in tissue perfusion, which led to the clubbing of the fingers. In addition, we said those splinter hemorrhages underneath their fingernails called Janaway lesions. We could also look for petechiae in the mouth, in the mucous membranes of the mouth, in the conjunctiva of the eye, on the upper palate, and even on the upper chest for the person. So those things should be all of concern to you. The other thing that we see sometimes, they call them Osler, O-S-L-E-R, Osler nodes. And these are like small, raised, kind of non-tender nodes on your fingers and toes. And I believe your textbook has some nice pictures of the Janaway lesions as well as the Osler nodes that you can take a look at. Those splinter hemorrhages and the petechiae that you might see are a result of little teeny weeny fragments of the vegetation. So teeny weeny vegetations that break off and make their way into the microcirculation, and then they cause those hemorrhages in the moist mucous membranes as well as under the fingernails. The other thing in terms of clinical manifestations that we should be taking a look at is the secondary clinical manifestations of an emboli, because we said the first problem that we would see would be related to the extra weight of the vegetations on the valves, and then the valve can't do its job, and then there are varying degrees of heart failure or poor perfusion that you're going to see. The other thing that you're going to see is that secondary problem of the vegetation breaking off in 25 to 50% of the patients. And how will that manifest itself? Well, if it breaks off and it makes its way to the spleen, you're going to have sharp upper right quadrant pain. You might have splenomegaly. If it breaks off and it gets into the renal artery, you might see severe flank pain. You may say hematuria. You may even see azotemia. Of course, if it breaks off and it moves into the extremities, it will manifest itself as a DVT, so it'll be red and swollen and somewhat painful. If it wasn't taken care of, eventually it will lead to gangrene if it's completely occlusive. If it makes its way to the brain, it will manifest itself as a stroke. It will look the same as any other stroke. And of course, if the problem is on the right side of the heart, it will look like the person has a pulmonary embolism and all the signs and symptoms that you know to be true for a pulmonary embolism. Okay, now we're going to take a look at collaborative. Oh, we have to do diagnostic studies. Hold on one second. Okay, for diagnostic studies, a health history is going to be extremely important for you. You're going to ask them about what's been going on in the last 3 to 6 months. Have you had any dental procedures, any urologic procedures, like a cystoscope, any GYN procedures, cardiac cath, surgery, dialysis? Have you had any skin or respiratory tract infections? And is there any previous history of IVDA, IV drug abuse? We're going to want to get, for this person, want to get blood cultures. We want to get 2 sets of blood cultures 30 minutes apart. And in 90% of the patients, we will have positive blood cultures. So we are going to get a great health history. We want to have the cultures, 2 sets, 30 minutes apart. 90% will be positive. But even if the blood is negative and there are clinical signs and symptoms, they'll keep the blood for 3 weeks and see if anything grows in there. So what are other clinical signs and symptoms? That is the new or the changed murmur that we talked about, and any of the splinter hemorrhages or the peti, any of those clinical manifestations we just talked about. In addition to that, we will probably see a mild elevation in the white blood cells if it's an acute infection, and probably not any kind of an increase in the WBCs if it's a subacute infection. We may see a mild elevation in the SED rate, indicating that there is inflammation. May see C-reactive protein, an elevation in C-reactive protein, again, indicating that there's some inflammation going on. We certainly were looking for a new or a changed murmur. Other diagnostic tests. We would be doing an echocardiogram, or, maybe a regular, maybe a TEE for the 3D view. And we would be looking for an intracardiac mass or those vegetations that are on the valves. A chest x-ray will tell us a lot about cardiomegaly and for those subacute cases. Perhaps a cardiac cath, get in there, drive around, see what's going on. And see what else. I think that's about it. Prophylactic treatment and drug therapy. A word about prophylactic treatment. Years ago, we would give anybody who had a murmur, some sort of a structural defect to the heart, they would take a prophylactic antibiotic before any kind of a procedure. And that was not evidence-based practice. That was just somebody's idea that would prevent them from getting endocarditis. Well, when it was actually studied, they found that there was no less incidence of developing endocarditis with those who took an antibiotic versus those that did not take an antibiotic. But we have a significant problem with drug resistance and antibiotics. So current practice, based on best practices, is not to give prophylactic antibiotics. Now, I know I could probably poll the class, and 5 people say they know somebody who still takes prophylactic antibiotics. And I have no doubt that that's the case, but the physician is not current in their thinking and their practice. And so, I just wanted you to know what is evidence-based practice. No prophylactic antibiotics. Okay, let's talk about drug therapy for somebody with endocarditis. In terms of drug therapy, there is very aggressive administration of IV antibiotics over the course of several weeks. I'm going to say that again. We administer very aggressive IV antibiotics over the course of several weeks. We make sure that we do a culture and sensitivity so that we know that we're treating with the right drug and not just treating with some broad spectrum antibiotic. These infections are very difficult to kill because remember that vegetation is kind of entrapped in the blood clots that were on those valves. So it's really hard to get at, and there's a high incidence of relapse. So a lot of times, because it takes several weeks to kill these bacteria, we are sending these patients home with PICC lines. And there's a lot of education associated with teaching the family how to administer these antibiotics. Home care nurses will go out and administer these and keep an eye on the patient. But again, I'm going to say again, it is aggressive IV therapy for several weeks, begins in the inpatient setting and ends in the outpatient setting. A lot of education is necessary. In order to completely eradicate it, like I said, it takes several weeks. A relapse is common. We often are doing serum antibiotic levels to make sure that we have therapeutic dosing, like vancomycin, peak and trough type of a thing. We certainly are watching renal function because we're probably going to be giving a nephrotoxic drug like vancomycin. These people, remember, they have 90% will have a low-grade fever, fatigue, malaise. So we will be treating with Tylenol or Motrin for the fever. So rest and fluids are indicated. Most likely, the person will be on anticoagulants. We don't want any more blood clots for this person. All right, we're going to move on to nursing assessment and diagnoses. Okay, let's think about nursing assessments. Vital signs. A thorough cardiac assessment, listening to all of the valves. All people eat turkey meat. Ape to man. Make sure that you remember how to listen and do a cardiac assessment. Where to listen to the valves. Do you listen with the bell or the diaphragm? Or both? Yes, you do listen with both. Remember that you put the diaphragm on against the person's skin snugly. It's a tight fit, as opposed to the bell is lightly laid on the skin to try and cut the sound. So vital signs, we're listening for a new or a changed murmur. We're looking and assessing the patient for arthralgia, they just don't feel comfortable, joint pain, decrease in range of motion. Make sure that you inspect the oral mucosa, the conjunctiva. You want to look at the chest. You're looking for petechiae, splinter hemorrhages. You're looking for complications of an emboli, the azotemia or the flank pain or the splenomegaly. And actually, I forgot, I should have said, I'm thinking back to interventions, and we said that drug therapy, we get the cultures And then we start the aggressive drug therapy, IV drug therapy. And I want to make sure that you remember to culture first before the antibiotic. I have a note here on my page that reminds you of that. We have tested that every single test so far because sometimes that's something that we forget. So culture before you give an antibiotic. Antibiotics begin immediately following the culture. And when we're talking about infective endocarditis, it's mostly antibiotics, but in a rare occasion, there is surgical intervention if there's severe heart failure because the vegetations are causing such valvular dysfunction. Okay, so let's move on to nursing diagnoses. Certainly, decreased cardiac output related to valvular incompetence, as evidenced by murmur, dyspnea, dysrhythmia, any of the signs and symptoms of heart failure. So when we're talking about infective endocarditis and you hear the words decreased cardiac output, you are going to replace those words with decreased blood flow. And decreased blood flow means decreased oxygen delivery. So there's not enough oxygen and nutrients to meet the demands of the tissues. The other diagnoses we could use would be risk for injury, emboli. And so we would, as evidenced by flank pain, hematuria, splenomegaly, any of the signs and symptoms of a DVT. Certainly activity intolerance is a great diagnosis. Hyperthermia if there's a fever. When we discuss planning, we should be talking about all of the things that we've talked about all semester in terms of monitoring hemodynamic status. So monitoring all the signs and symptoms of perfusion, of vital signs. So I think that should be something that is secondhand for you at this point. Now, I'm just giving a quick look over my notes to make sure that I've said everything that I want to say to this point. And 3 things I have in my notes that I want to make sure I tell you. Infective endocarditis damages valves with the growths and the vegetations on the leaflets. I want to make sure you remember that. The valve is already damaged, but the vegetation, that is a combination of the bacteria as well as the thrombus, does further damage to the leaflet. Those lesions, the vegetative lesions, put the patient at risk for the emboli, which is what we said. They can also cause erosion and perforation in the heart. So that is an additional complication, far less common. And valvular regurgitation or stenosis is, or what they call valvular insufficiency, can occur because of the vegetations. And we did say that the patient is at risk for developing heart failure, certainly right-sided or left-sided. And of course, we know we don't have one lung without having the other develop too. Okay, now we're going to move on and talk about pericarditis. Okay, what is pericarditis? Pericarditis is an inflammation of the pericardium. And when I say the word inflammation, you should be saying to yourself, oh, I understand inflammation. I understand that there is going to be histamine that is released to the area, which is going to change the permeability. I understand that there is going to be increased clotting, increased fibrin in that area. I understand that there will be increase in neutrophils coming to that area because you understand the concept of inflammation. So because it is an inflammation of the pericardium, the pericardium actually gets this shaggy kind of a inflamed look to it. We'll take a look at that in the next slide. So acute pericarditis lasts about 1 to 2 weeks. It will resolve on its own. The inflammation often involves the adjoining diaphragm, so not only the heart being inflamed, but the diaphragm. It is a common complication following an MI. In 90% of the cases, it is idiopathic, meaning they don't know what it comes from. They presume it is from a virus. In some instances, it is autoimmune, as in lupus, because that is what the body decided to attack. Other things that can cause acute pericarditis is chest radiation, chest trauma, maybe even a neoplasm might be a culprit in there. Okay, clinical manifestations. Here, take a look at this picture. This is the shaggy appearance that we talked about as a result of that inflammation. I want to talk a couple minutes about clinical manifestations, diagnosis, and management. So clinical manifestations: severe sudden stabbing chest pain that often radiates to the back and the arm. Okay, that can sound like an MI as well. Severe sudden stabbing, which is different than what most people explain for an MI. Most people say that it is a crushing pain for an MI. So, severe sudden stabbing pain that is aggravated by deep breaths, laying back, coughing, or inhaling. Let me say that again. A severe sudden stabbing pain, which sounds a little different than an MI because MIs usually have a crushing pain. The pain is aggravated when the person takes a deep breath and inhales or puts pressure on the heart, when the person lays back, or when the person is coughing. It is relieved when they lean forward and take shallow breaths. Like many of the inflammatory disorders, low-grade temperature, malaise. You may even hear a pericardial friction rub. Now let's think about the difference between a pericardial friction rub and a pleural friction rub. So, when we're talking about a pleural friction rub, we ask the patient, when we're talking about a pericardial friction rub, we ask the patient to hold their breath. And when they hold their breath, if we can hear the rub, we know it's their heart. And vice versa. The pericardial friction rub sounds like a wet finger on a blown up balloon, sliding it back and forth, making that kind of a noise. You should know that the pericardial friction rub can come and go. It is best heard at the left lower sternal border. Okay, some diagnostic things. What are we going to do to find out? Well, we're going to do a 12-lead EKG. We're going to have to do a CBC. We're running in some cardiac enzymes. A SED rate will tell us about inflammation. We'll do an ANA because we're really looking for lupus. Blood cultures are probably important to do right off the bat. What are we going to do? We are going to treat this with NSAIDs. It is an inflammatory condition which causes a lot of pain, and we're going to treat it with NSAIDs. As soon as I say treat it with NSAIDs, you should be saying, oh, this is really bad for the person's gut. And I'm going to want to use something like maybe a PPI to keep the acid down. I might even want to use a mucosal protectant such as Carafate. I'm going to provide rest for this patient. I'm going to try to find comfort for them. Maybe having them lean forward in that tripod position might help. A word about the NSAIDs. It's usually very high doses. You know, Advil comes in 200 milligram tablets, and we usually take 200 or 400 milligrams, but we can administer up to 800 milligrams. You will be watching the patient for signs and symptoms of a pleural effusion that could eventually lead to cardiac tamponade. We usually avoid the use of anticoagulants. Most, like I said, resolve in 1 to 2 weeks on their own. Rest and positioning high doses of NSAIDs is the ticket. We're moving on to structural defects of the heart. Things you should remember. The heart has 4 valves. They are very thin, almost paper-like, and they allow for forward flow of blood, or they prevent backflow or regurgitation. Let me say that again. Forward flow of blood is something that we've been talking about all semester. Forward flow of blood means that the blood comes in to the right atrium and it moves through the valve, it moves into the left atrium, or to the right ventricle, from the right atrium to the right ventricle. It moves out to the lungs, comes back into the left side of the heart, fills the left atrium, moves into the left ventricle, and from the left ventricle, it perfuses the body. And we have talked about conditions, heart failure being one, that there is damage and there's difficulty with forward flow. And in heart failure, it was extra volume, or the cardiac muscle itself was failing, or the afterload or vascular resistance was just too high for the heart to overcome. Well, today we're talking about this valve problem in which the valve does not allow for forward flow. So we are really talking about, in the most severe form, heart failure. So let me just give you a quick run through about the normal valves. So there are 4 valves. They're thin and they're paper-like, and they are very elastic, and they move. They move and they prevent backflow. They promote forward flow. They open and close in response to pressure changes in the gradient in the different chambers. So when the pressure is high in one chamber, the valve opens and moves the blood into the next chamber. During the ventricular filling of diastole, actually, I'm not even saying that. You guys will memorize it, and it's too much. Try to go back and try to visualize the blood moving through the mitral valve, and the tricuspid. And remember, we have the semilunar valves, the aortic and the pulmonic valve. Just know that the valves push blood forward. The valves allow for forward flow and they prevent backward flow. The tricuspid and the mitral valve and the aortic and the pulmonic valve, they move in harmony and rhythm such that they're opening and closing two at a time. And so that's why when the most common sound that we hear in heart failure is that S3 sound, that's what happens when there's extra volume and they're not working properly together. Okay, but when a valve has dysfunction, the forward flow is affected. So there are two categories, like I said, two categories of valvular dysfunction. The one is stenosis, and the other is regurgitation. And we're going to look at stenosis and regurgitation. I want you to look at this picture here, this structural picture that we have. Actually, I have better pictures coming forward, so that's fine. Let's advance the slide, and we're going to talk about mitral valve stenosis. When we talk about a valve being stenotic or having stenosis, the valve becomes thick and non-compliant. And they say it has the familiar fish mouth appearance. So stenosis would be, by definition, here's some definitions for you. The leaflets fuse together and cannot fully open or close. The valve components become thick and the orifice or the opening becomes narrow. And so this fusing of the leaflets and the thick narrowing of the opening causes resistance of blood flow across the valve. That means it's hard for the blood to get through that stenotic valve. I would say you can think of that stenotic valve. It's not exactly the same, but you know how you're going down the turnpike and there's like 6 or 7 lanes, and then they condense you all the way down to 2 lanes to get through the toll booth. That's kind of what stenosis is. So you have all this blood volume coming through, and then this tiny little opening for all of that blood to move into the next chamber. So just like traffic gets backed up, so does the blood as it tries to get through that valve that is stenotic. So when the traffic gets all backed up and the blood is pushing back, it affects the previous chamber, the chamber before the valves. Because that chamber has an increase in afterload. Let's think about that. So we had all of those cars coming down the 8-lane highway, or all of the blood rushing into the left atrium. And then they funneled us to 2 cars to go through the toll booth. They funneled all that blood into a tiny little orifice. So the pressure that the left atrium has to overcome to get through that valve is greater, and thus we say afterload is increased, and pressure, and the blood backs up into that previous chamber. The blood is backing up. It's like the traffic on the turnpike. It just can't get through. And so that's how we cause damage. Okay, so who has mitral valve stenosis? People who've had rheumatic heart disease. It causes scarring which shortens and thickens the valve, which gives it that, quote, familiar fish mouth appearance. I'm going to advance the slide so we can see that fish mouth appearance. There it is. So then, like I said, it becomes difficult to pump from the left atrium into the left ventricle. And then the long-term increase in pressure in the left atrium ends up, and when it backs up into the left atrium, the traffic is all backed up into the left atrium. Eventually, it backs up and it starts filling in all the other tributaries that are feeding the highway. So the tributary that's feeding the highway of the left atrium is the lungs. So we have that congested area, which is reduced to a 2-lane highway, or we say it is that valvular stenosis. It's thick, it's short, it's non-compliant, and the blood backs up and the pressure in the left atrium becomes so great. And when the pressure in the left atrium becomes so great, it eventually pushes the traffic back into the lungs, and it manifests itself as pulmonary edema.
Dad said it was bueno.
Now, the thing about mitral valve stenosis is, in its most severe form, it backs up into the lungs, causes pulmonary edema or increased pulmonary pressure or pulmonary hypertension. And then that pulmonary hypertension ends up resulting in right-sided heart failure. So now we have a right and left-sided failure. But most mitral valve stenosis is benign. People have it for years. It doesn't cause a lot of problems. So in terms of signs and symptoms, we would be talking about, like, in the early signs, in the most severe form, it would look like left-sided heart failure followed by, or leading to, whatever you want to say, right-sided heart failure. But when it starts to cause a little bit of a problem, the person might have fatigue or dyspnea. And why would they have fatigue and dyspnea? Because really, remember, the problem with heart failure is poor tissue perfusion. So fatigue and dyspnea are signs of poor tissue perfusion. There may be orthopnea because there's a little bit of pulmonary hypertension. We might hear a murmur or an irregular beat. They might have palpitations. AFib can be common. Now, of course, in the late stages, when we're talking about, heart failure-like conditions, hemoptysis, angina, all the signs of decreased tissue perfusion, could even result in a stroke from an emboli because of the stasis. But remember, in most instances, there's not much going on with the person. It's a fairly benign condition. I just went through very quickly how the blood backs up and how forward flow is affected. If you do not understand what I just said about forward flow and how it backs up into the pulmonary capillary beds, and that increases the pulmonary pressure, and that pulmonary pressure leads to an increased vascular resistance from the right side of the heart, which leads to right-sided heart failure. If you're not hanging on my every word and understanding, then there are many, many, many concepts this semester that you don't get. You need to get with me or Dr. Roy ASAP, because it is critical that you understand retrograde flow, that you understand what happens when forward flow is impaired and some of the things that impair forward flow. Okay, I'm going to move on. Well, I'm going to move on and I'm going to list these clinical manifestations of stenosis because there's a slide and I did it on the last one and I should have advanced it. So it's often benign with relatively few signs and symptoms, but as signs and symptoms come on, it's signs of fatigue, dyspnea, orthopnea, maybe a murmur, maybe a palpitation, an irregular beat. AFib is a common problem. Later on, we'll see signs and symptoms of heart failure, angina related to decreased cardiac output or altered tissue perfusion, maybe even hemoptysis. Now we're moving on to regurgitation. Regurgitation is an insufficient or incompetent valve that doesn't close completely. We call them regurgitant valves. So this is a valve that allows regurgitation of blood through the valve and back into the chamber that it just came from. Any defect of the valve structures can lead to regurgitation. Most times it's caused by rheumatic heart disease, an MI that has caused damage, infective endocarditis, or prolapse, which I'll mention in a couple of minutes. So the valve is incompetent. It allows backward flow of blood from the left ventricle back to the left atrium. So both the atrium and the ventricle have to work harder in order to preserve cardiac output. So let's think about that. What's supposed to happen is the blood moves from the left atrium into, when the pressure in the left atrium gets so high, the blood moves through the valve, and the valve is supposed to open up like the doors swing open, and the blood rushes down into the left ventricle, and when the left ventricle, when it gets nice and full, the doors slam shut, and that's it. There's no backflow. But when we have regurgitation, what happens is the pressure in the left atrium gets increased, the doors swing open, the blood moves from the left atrium into the left ventricle, and then it's time for the doors to close, but the doors don't close all the way. And if the doors don't close all the way, some of the blood pushes back up into the left atrium. So then the ventricle has to work harder because it doesn't have as much stroke volume, so cardiac output is down. The atrium is working harder because it has more blood than it's supposed to in there. So when we have chronic regurgitation, the extra volume loads can result in atrial enlargement, and the extra work to the left ventricle can lead to left ventricular hypertrophy. And of course, when we hear left ventricular hypertrophy, you should be saying, uh-oh, my person's at risk for developing heart failure. And most people with mitral valve regurgitation are asymptomatic for years. Then they may, in the worst situation, then they may begin to show signs of left ventricular failure. We watch them very, very closely. And before they get to the point where they have left ventricular failure, we would consider doing surgical repair we'll talk about that in a little bit, to fix the valve or replace the valve altogether. A quick word about mitral valve prolapse. Mitral valve prolapse has an unknown etiology. It's the most common form of valvular heart disease. It occurs 2 times more frequently in women than men. And there is There's an abnormality of the leaflets, the muscles, and the cordae tendini, which are the ones that open and close the valves, the little leaflets that, the cordae tendini control the little leaflets to prevent them from buckling in and out. What prolapse is that the little leaflets, in the mitral valve, there are 2 little leaflets, and they are supposed to form a nice seal. When the ventricle is filling, they form a nice seal, and they don't allow any backflow up into the atrium. When you have prolapse, one of those little flappers actually falls back up into the atrium and allows retrograde blood flow or backflow from the left ventricle into the left atrium. I'll show you a picture. I'll show you a picture right now. We'll advance the slide. You can see here in the middle of that slide, you can see the arrow, and you can see a left ventricular hypertrophy. You can see right or left atrial dilatation. And you can also see right by that arrow in the middle that the little leaflet has fallen back into the left atrium, and it is allowing retrograde blood flow. It's usually a very benign condition, but serious complications can occur. You could have regurgitation, you could have infective endocarditis, you can end up with ischemia, but it is usually very benign. They don't know why we get it. People have it, and it's really no big deal. You may hear a murmur. You may even hear a click. That's mitral valve prolapse, like I said. Important takeaway, prolapse, it's the most common. It's usually benign. It's more common in women than men. Maybe you'll be lucky enough to hear a valve, and in terms of a murmur. Okay, aortic stenosis is the next thing that we're going to talk about. It can come from rheumatic heart disease, or you may have a congenital problem. If you have a congenital defect, it's usually seen in children and adolescents. And rheumatic heart disease is something. The aortic stenosis from rheumatic heart disease is something that we see from adults. Aortic stenosis can come, like I said, from the rheumatic heart disease. What is aortic stenosis? It is an obstruction of flow out of the left ventricle into the aorta, resulting in left ventricular hypertrophy and an increased need for oxygen because of the size of the myocardium, because of the increased myocardial mass. So let's think about this. We know what stenosis is. We know it's a thickening. We know it's narrowing. And the blood, when we're talking about the aorta, the massive blood coming down the turnpike, 8, 10, 12 lanes coming down, all the way compressed down into those 2 little lanes going through the toll booth. That is aortic stenosis. And now we're talking about directly affecting cardiac output. And we are also talking about vascular resistance. It is, afterload is very high. The amount of pressure that the heart has to overcome in order to get blood out of the heart into the body. So when we're talking about aortic stenosis, we're talking about a left ventricle that is working tremendously hard. And so as the disease progresses and all the compensatory mechanisms that we saw for heart failure, every time cardiac output is low, we have the same compensatory mechanisms. According to your textbook, signs and symptoms occur when the valve is 1/3 the normal size, and we see that classic triad of symptoms. Put a circle, put a star, highlight, do something to these classic triad symptoms: angina, syncope, exertional dyspnea. They start to look like signs of left heart failure, because that's what it is. So you have a red flag, a neon light, something that is saying to you, angina, syncope, exertional dyspnea is the classic triad of symptoms that indicates aortic stenosis.
Nice.
More than likely, you will hear a murmur. Something else that is important for you to note is that we do not give these patients, despite the fact that there's angina, we do not give these patients nitro. The reason we don't give the patient nitro is because we need to keep preload high. We need to keep preload high so that that is extra pressure to help open that very stiff valve. Next, we're going to be talking about aortic valve regurgitation. Aortic valve regurgitation is retrograde blood flow from the ascending aorta into the left ventricle, which results in fluid volume overload. It is most often caused by trauma, and that trauma is often an acute aortic dissection. It is life-threatening. Let's talk about retrograde blood flow from an aortic dissection. Let's remember from last year what an aortic dissection is. You remember that the lining of your blood vessels, there's actually several layers. It's not just one. In the capillary, it's well thick. But in the other vessels, there's several different layers to the vessels. And when you have a dissection, you get a tiny little tear, I'm going to say, in the lining of your vessels. And that vessel then rips. The blood dives down in between the layers of the vessel and eventually and peels apart such that the blood blocks off forward flow. Like the vessel is ripped and the blood is no longer in the vessel feeding blood to the rest of the body. It is just sliding down in between the layers of the vessel. And when that happens, imagine your heart pumping, pumping, pumping all of this blood, and then all of a sudden the blood takes off and rushes in between the layers of the vessels, and it becomes like a major roadblock, and the blood can't move forward, and then there is it's life-threatening, an emergent retrograde blood flow. That means all of the blood that would have been running down to the body backs up and blows way back into the heart. So it is a life-threatening emergency because it has immediate fluid volume overload and can do structural damage to the heart. I'm looking to see if I want to say anything else about that for you. No, I don't think so. Let's move on. Okay. In terms of tricuspid and pulmonic problems, I'm going to run through those very, very quickly. It is very rare that we have a tricuspid or a pulmonic problem. If it is, it would be somebody who has IV drug abuse or congenital pulmonary problem. So could result in left or right ventricular hypertrophy or right atrial enlargement. It could eventually lead to right-sided heart failure, but again, very uncommon. Understanding the basic principles of, poor forward flow will get you to any answer you need to know about tricuspid and pulmonic valve structures. Not typically common, so more testable and more noteworthy of your time studying is problems on the left side of the heart. Remember that all the valve disorders, the signs and symptoms are basically the same. Fatigue, dyspnea, orthopnea, murmurs, arrhythmias, AFib is common, angina, hemoptysis, pulmonary edema. I'll say those one more time because I'm fast. The signs and symptoms are very, very common to almost all the valve disorders. Fatigue, dyspnea, orthopnea, murmurs, arrhythmias, particularly AFib, angina, hemoptysis are very common. Okay, in terms of diagnostic studies, you want a good history and physical, noting any kind of a congenital problem, particularly rheumatic heart disease, when the person was a child. We're looking at a chest x-ray because we're looking for cardiomegaly, an EKG, an echocardiogram, an echo with 3D Doppler, a TEE, which are all those tests that give us imaging of the myocardium of the heart muscle. A cardiac cath is certainly an option in terms of diagnosing because these are structural problems. So it's something we're going to go in there and look at. Okay. Taking care of. Collaborative care, conservative therapy. Let's talk about first some of the basic things. In almost all of these conditions, especially the ones that I spent most time on, which is the left side of the heart, most times, like I said, most of the conditions are benign, but as they start to become less benign, we see fatigue, orthopnea, dyspnea, exercise exertion, dyspnea on exertion. So we are thinking about heart failure. So some of the basic things that we do for heart failure, sodium restriction. We're talking about using ACE inhibitors, maybe using the positive ionotropes, diuretics, beta blockers, anticoagulants. We're watching for signs and symptoms of AFib and emboli. So maybe aspirin therapy or Plavix are indicated for these people. We also have listed here percutaneous transluminal balloon valvuloplasty. A lot of words. What does it mean? Well, what is that? It is a procedure done through femoral access, and it has a balloon-tipped catheter that's inflated to open a stenotic valve. So it's a single or a double lumen, or a double balloon, and they drive in there, just like they would a cardiac cath. They place it in. Okay, so then we can also talk about surgical repair, and we can talk about valve repair, which they call valvuloplasty, where they use sutures to fix torn leaflets, and it's very minimally invasive. They get in there with the needle and the thread, and they kind of like do a nip and a tuck and repair anything that has been ripped. And then the valve is technically good as new. You can take a look in your textbook. There are a couple of pictures of those procedures. Then there is valve replacement that can be done. Certainly it's more invasive. We have bovine and porcine and human valves. If the person has valve replacement, important to remember is that they need long-term anticoagulation in order to prevent thrombi. Here's a couple pictures of some of the valves, some of the mechanical valves that you might see in there. It's from your textbook. I thought I'd include it. And we're coming up on one of the last slides. Nursing assessment, diagnosis, planning, implementation. What is important for you to know? Decreased cardiac output is the main diagnosis. From the decreased cardiac output, there is decreased tissue perfusion. There could be impaired gas exchange, activity intolerance, fluid volume overload, knowledge deficit. We talked about treating like you would for heart failure, and then some of the conservative management that we talked about. There's a lot of health promotion and encouraging living in a healthy lifestyle. How do you evaluate the effectiveness of your care? You are looking for signs that perfusion is better. You are looking for signs that fluid status is better. You are looking for improved exercise tolerance, decrease in the dyspnea, decrease in orthopnea. That's how we know that our teaching our care has been effective. Now, I want you to I don't want you to study a lot about myopathy, but I want you to know that there is dilated cardiac cardiomyopathy and hypertrophic cardiomyopathy. Dilated cardiomyopathy, the left ventricle becomes dilated, the wall becomes thick, and the size of the chamber becomes much larger than it was before. Cardiomyopathy manifests itself just like heart failure. So, when we talk about myopathy, we're really talking about a group of diseases that directly affects the structure or the ability of the myocardium to function. And it can be primary or secondary. It can be as a result of alcohol or cocaine use. And there are three: dilated, hypertrophic, and restrictive. Like I said, I have given you two slides here. It looks like I have given you just a picture of dilated cardiomyopathy, again, where the ventricle becomes enlarged and thin-walled. Here is a picture of hypertrophic cardiomyopathy, which is exactly what we talked about when we talked about heart failure. You can see in the middle how tiny that left ventricle is because the muscle is so thick, which impairs the amount of blood that can enter into that. So this person has significant heart failure. Again, a picture. Let me see. Cardiomyopathy, like I said, eventually leads to heart failure. There's a decrease in exercise tolerance, fatigue, dyspnea, orthopnea. That's initially what we see. How do we diagnose it? Just like heart failure, with a Doppler, we are going to do an echocardiogram or echo in order to check the ejection fraction. We might do a chest x-ray. We might do a BNP, pro-BNP, maybe a cardiac cath. How do we treat it? We treat it just like we do other heart failures. These people are often candidates for heart transplants because cardiomyopathy affects young African American men far more than any other group of people. It is idiopathic. It is not understood. It is, race and gender definitely predispose a person to developing this idiopathic form of cardiomyopathy. Thank you for listening. I appreciate your time. If you have any questions, please, please, please come see me. Thank you. That's all, folks. We'll see you in class.